Welcome back to Med School Mind Maps, everybody. Today I want to do a whole video on primary and secondary CNS tumors. So that's tumors that arise in the brain and the spinal cord. So we're going to start here at metastatic tumors because they're just more common, especially in adults. And we have three locations where typically metastatic tumors arise from. We have the lung, the breast, and the skin. In lung, you can suggest the patient probably has a smoking history, or maybe they have a history of ingesting a bunch of toxins made from occupation. And the most common types of lung cancers that will spread to the brain are small cell carcinomas, as you can see here in a histology image. You have nuclei that exhibit salt and pepper chromatin with brisk mitotic activity, so these cells are replicating very fast. They're sometimes referred to as small blue cells, so that's small cell carcinoma, and then adenocarcinoma. And you can see adenocarcinoma here with glands forming within the tumor. That's a good way to distinguish this on histology image. But we're not going to go in depth on these types of tumors today. We're just going to talk about what they look like when they metastasize to the brain. And then breast cancer, you can see this in women, most common, and then skin cancer, which is typically melanoma, most common skin cancer to metastasize. So let's go over here to the locations. So for the locations of a metastatic tumor, we're going to see most of these tumors pop up in the cerebral hemispheres. So this is above the brainstem, above the cerebellum. So typically you can distinguish this as supratentorial. So you have the tentorial part of the dura mater that separates the lower parts like cerebellum and brainstem from the cerebral hemispheres. 80% of the metastatic tumors will come from this location. And we have 50% arising in the cerebellum itself, so that's the area in the back of the brain involved with coordination, movement, and then we have the brainstem, which is most of your vital functions, breathing, cardiac outputs, and everything like that. So let's go into more of the pathophysiology of how metastatic tumor arrives in the brain. So first we have a release of proteases in the specific organ of origin. So for example, we have a tumor arising in the lung. That tumor is going to release proteases that digest the endothelium, which are the cells lining the blood cells. So they digest that area, and then they release VEGF to allow to grow blood vessels to access that vascular pattern. And this is referred to as angiogenesis. So the tumors, these tumors down here, specifically, are trying to get to the blood vessels so that they can travel throughout the body. So once they reach the brain, and they spread again hematogenously through the blood, they can be identified through a CT scan or MRI specifically. MRI is most common to see soft tissue lesions. And they look like these ring-enhancing lesions here. So this is your cerebellum. As you can see, this is a sagittal cut. And you can see tumor here, 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 anywhere. You can see these ring-enhancing lesions. Now, this is very important to know that these are METs, because typically if it's a primary tumor, you're just going to have one lesion, very rarely maybe two lesions. But because these are everywhere, this is just to show that that tumor is already metastasized and it's kind of popping up everywhere because this whole brain is obviously supplied through blood vessels. Okay, so this is a gross image. So this is a tumor here, a metastatic tumor. Right here you can see some surrounding edema. That's like it's pushed the ventricles a little bit to the right here on this image. This would be the patient's left side, so it's pushing it to the left, and that's caused by increased intracranial pressure from the tumor itself, so more mass, and then its surrounding edema. All right, so that pretty much takes care of metastatic tumors. Let's now shift over to primary CNS tumors. And how I have this kind of split up on my mind map is I have generally the main pathophysiology, etiologies, and symptoms of primary CNS tumors itself, and then I'll break it down into the specific types of tumors down here. So not to confuse y'all, let's just start here with the common causes of primary CNS tumors, and we're going to cause as risk factors. So typically, primary CNS tumors are caused by ionizing radiation. And this is actually the only known environmental risk factor out there. So smoking, any sporadic causes aren't typically the cause of a brain tumor. It's typically radiation. So let's say a patient comes in with a glioblastoma. Well, if they don't have any familial syndromes or they aren't immunosuppressed, then it's pretty safe to say that ionizing radiation was probably the cause. How much radiation is safe for a person to have throughout their lifetime? Well, that's pretty tough to say. Typically, a CT scan, I don't have the specific numbers off the top of my head, but a CT scan can typically get you maybe 1 day's worth of normal radiation, since everybody is going to accumulate radiation over time just from natural radiation waves coming from outer space. So imaging is pretty typically safe. You just don't want to be having imaging all the time or be put in situations where you're exposed to a lot of ionizing radiation. The next one is immunosuppression. So this is very common in people with autoimmune deficiency syndrome or AIDS, or it could be because of age or any other host factors, maybe an organ transplant. But this is going to increase your risk for primary CNS tumors, and specifically CNS lymphoma. And we'll get into that more later in the video. And lastly, familial syndromes. These are just genetic causes that you inherit from your family. This occurs for about 5% of cases for primary CNS tumors. So let's move on to more of the symptoms. I usually have pathophysiologies in blue, and the only pathophysiology you need to know is obviously these tumors are arising in the CNS. So let's look at the symptoms that you typically present with, depending on where it presents in the brain, as a focal lesion. So let's start here in the frontal lobe. And the frontal lobe, of course, is involved in like personality planning, judgment. So these are typically the symptoms that you would see if someone had a tumor in their frontal lobe disrupting its normal function. Temporal lobe, pretty similar. It's going to be involved with memory. You have that hippocampus there. Behavior, hearing, or your primary auditory cortex in the temporal lobe. Emotions, you have those mammillary glands in the temporal lobe. And language. So you have Wernicke's area, you have Wernicke's area in the temporal lobe, and of course Broca's areas in the frontal lobe. But then you have some of those arcuate fasciculus in that temporal lobe as well. So language comprehension, language is going to be a little bit disrupted. And then the pituitary gland, if it arises there, of course you're going to have hormonal issues, maybe some growth issues from growth hormone, fertility issues. So those are seen in pituitary gland, primary focal CNS tumors. Now moving on to the brainstem. Of course, the brainstem's more in charge of those vital functions of the body, like breathing, blood pressure, heart rate, and swallowing. So if the patients have any trouble with those, maybe a primary CNS tumor should be on your radar. Cerebellum's obviously involved with balance, coordination, and fine muscle control. So that's pretty self-explanatory. Tumor comes from the cerebellum. Look for those symptoms. Occipital lobe, of course, primary visual cortex is in the back there. So if a patient is having trouble with vision, that's the only focal lesion, maybe suspect a tumor in that occipital area. And then we have the parietal lobe. And the parietal lobe, usually the right part of the parietal lobe, is in charge of like your hemi-neglect syndrome, so paying attention to both sides of the body. It's in charge of calculations, sensations, reading, and writing. All right, so let's look at more of the other complications that you can have from a primary brain tumor. We're going to start out with bleeding. And this occurs whenever you have a hemorrhage of the tumor into the tumor and surrounding area of the brain. And specifically, I want to talk about glioblastomas here. Glioblastomas are very much fast-growing tumors, and they have a lot of angiogenesis, so VEGF production, which again is in charge of growing new blood vessels to kind of spread and grow. So in glioblastomas, they basically grow faster than the blood vessels themselves can grow. So this causes bleeding and hemorrhage. So that is a common cause of CNS symptoms. And then of course, the next one we're talking about is hydrocephalus. And again, hydrocephalus, if you can see in this image, we have the ventricle here. So the ventricle is going to store CSF. It's going to be produced there in the lateral ventricle, and this is going to go down the foramen Monro into the third ventricle, and then down the cerebral aqueduct to the fourth ventricle, and spread throughout the spinal cord through foramen Luschka, etc. So if the tumor is compressing on anywhere in this CSF production system, then that CSF can back up, causing the lateral ventricles, fourth ventricle, third ventricle, cerebral aqueduct, etc., to get larger. That increases intracranial pressure. So hydrocephalus is a common symptom associated with tumors. And this is seen in tumors of the posterior fossa due to the proximity of cerebral aqueduct and fourth ventricle. So that's around this area here. Okay, so the last one to talk about is increased intracranial pressure. Now, increased intracranial pressure is pretty much caused by three things. So you can have increased blood supply to the brain, you can have increased mass, or increased CSF. So let's just say you have a tumor, and that tumor is mass. So because there's more mass in the brain and that skull is fixed and doesn't allow any outlets, that tumor is going to get larger, and it can associate with hemorrhage as well. So that's going to be increased matter within the brain. Now, a little thing we have to be aware of is this is kind of how our body regulates at first intracranial pressure. So say you have high intracranial pressure, so what happens is your body is going to want to blow off a lot of CO2. So whenever you blow off CO2, you're going to have hypocapnia, so decreased CO2, which means your brain's getting plenty of oxygen really, and it doesn't need any more blood, so those vessels are going to constrict, and this is decreased cerebral blood flow. Quite oppositely, if you have increased CO2, it's hypercapnia. The cerebral vessels are going to dilate because your brain needs more oxygen. The brain uses a bunch of oxygen. It's 20% of blood flow to the body. So you can imagine that all the oxygen it needs, if it has a lot of CO2 in the blood, it's going to want to dilate to allow the oxygen to the blood. And this is going to cause increased cerebral blood flow. So increased intracranial pressure can present with hydrocephalus and cerebral edema. And this is because, of course, CSF obstruction, so the intracranial pressure disrupts that ventricular system, causing a CSF obstruction and increased hydrocephalus, and then cerebral edema. This is because, again, the vessels in the tumors can be leaky sometimes, especially in glioblastoma, and that causes fluid to leak out of the tumor, leading to cerebral edema. Now, here are more of the other signs and symptoms. So some of the symptoms, we'll see headache. So typically in a tumor headache, it's going to present very chronically, and it's going to be very persistent. And then it can get changed with positional. So imagine if you're laying on your back, that tumor can be pressing on a certain part of your brain, leading to a headache, or if you lay on your side, maybe that position of the tumor changes. It really just depends on where that tumor is in the body. And these tumors can feel very deep within the brain, just depending on where it is. And these are very persistent and they worsen through time. Sometimes you can be woken up by this headache. Now we're going to move on to some of the signs that we can see. So one of them is papilledema, and papilledema is just basically a side effect of increased intracranial pressure. So the optic nerve, which is not part of the, which is not a cranial, it's not like a typical cranial nerve, it's still part of the brain, so it's encapsulated by subarachnoid space. So the CSF system is going to be still around this nerve, the optic nerve that is. So as intracranial pressure rises, you can imagine that compresses the optic nerve, creating something called a tourniquet effect, leading to the autoplasmic flow being impaired. And if we look at a fundoscope image of your retina, so this is your retina here, this is a normal optic disc, and can you see, so this is your optic nerve, circle right here, and you can see that these lines are very distinct between the retina and the optic nerve. They're very sharp, so sharp disc margins. Now if we look at papilledema, the disc margins have been blurred because, again, that increased CSF constricts on that optic nerve, making it look blurry there. So that is papilledema. Now, something that I want to talk about now is the Cushing reflex, and this is basically the body's natural response to increased intracranial pressure. And how I want you all to remember this is through something that I kind of came up with here called the BP rule. So when BP is together, that's going to be increased blood pressure. Now when you separate the B and the P, it's going to be decreased heart rate, so bradycardia, and then decreased P. Sorry. So bradycardia is going to go over the P because that's going to be decreased pulse. And then for the B, it's going to be decreased breathing. So that's kind of how I remember the Cushing reflex, but let's go into more detail about what the Cushing reflex actually is. So what it is you have a physiological response to acute increased intracranial pressure. And this is going to signal impending herniation and death. So what happens is you have this formula, cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. So cerebral perfusion pressure is going to be directly related to mean arterial pressure and intracranial pressure. So you can imagine when you have increased intracranial pressure, because that's being subtracted from mean arterial pressure, that's going to lead to decreased cerebral perfusion pressure, leading to ischemia in the brain. So what's going to happen is the sympathetic outflow of the brain is going to have to increase to basically try to increase that cerebral perfusion pressure. So that's going to be leading to increased heart rate at first and increased BP, so that cerebral perfusion pressure can increase. Now later on, we don't know why, either thought due to activation of the baroreceptors in the aortic arch or crowded body or due to compression of intracranial portion of the vagus nerve, that heart rate is going to decrease. This is going to lead to brainstem compression and irregular reduced respirations. So that's what I was kind of talking about with that BP, increased blood pressure, and then when you separate the B and the P, those things are down, so B is going to be decreased breathing, and then P is going to be decreased pulse. So that's the Cushing reflex. Now, what I want to talk about is the individual brain cancers. And I have them kind of split up into children and adults for most common, and then I have tumors associated with genetic conditions, and that all kind of ties into each other. So let's first start out with the adult tumors, and the most common cause of an adult tumor is something called a meningioma. Now this is the #1 primary brain tumor in adults, and luckily it's more typically defined as benign, and it has a WHO grade of 1. So what I want to first do before we go on to meningioma is I want to discuss what a WHO grade actually is. And that's the World Health Organization's grading of what a tumor should be graded as. So 1 is more benign, less malignant. So if it's graded as a 1, that means that tumor is going to be slow growing, circumscribed, which means it's very easy to resect. So very good margins. And if it's a 4, which is the highest grade that it can get, that means it's more malignant and less benign, which means it's faster growing, it infiltrates more quickly, and is less resectable. So those tumor cells extend beyond the seen borders, really. So it's really hard to get all of it at once. So now let's go back to meningioma here. So what a meningioma is it's a tumor of meningothelial cells. Now, I bet you're wondering, what is a meningothelial cell even? What kind of cell even is that? Well, it's a cell that's associated with the arachnoid mater, and it's actually the most common cell type of the arachnoid mater. And what it actually does is you can pause the video and read this explanation that I got from AI, but that is exactly what a meningothelial cell actually does. Okay, so moving on, this meningothelial cell tumor is going to have very defined borders, and because it extends from the arachnoid mater, we're going to see it very much on the edges of the brain. So this is a gross image of a meningioma. You can see it's right next to the falx cerebri, and it's on top of the dura. So it comes from the arachnoid mater, but it's very easy to resect because it's very on the outside and has very clear borders. This is an MRI of one, so you can see this is a very classic meningioma. You can see the dura mater right here, and it's actually extending from the arachnoid mater, which is the second layer of the meninges, and then again in the gross image. All right, so let's look at some of the symptoms that you can get from meningioma, and I don't really have too many specific symptoms. Just know that they're secondary to compression of adjacent tissue. So some of them are seizures, headache, nausea, and vomiting. Of course, if it compresses the areas that cause nausea and vomiting, headache's pretty easy to kind of associate with it. Seizures, so frontal lobe, and then confusion. So if it's in the frontal lobe, it can typically present with confusion. And then if it's in that area that regulates sleep, so like maybe the hypothalamus compressing them there, maybe some hearing loss, so maybe on the temporal lobe, and issues with vision if it's on the occipital lobe. So now that's pretty much the symptoms of a meningioma. Let's look at some of the workup. So obviously we're going to want to get an MRI if someone comes in with symptoms of a meningioma. And what we're going to see is, with this one specifically, this one's attached to the falx cerebri, which is the middle part of the dura that extends between the two cerebral hemispheres. Now, looking at a biopsy of this, what I want y'all to burn into your brains is that you're going to have whorled, bland, plump spindle cells. So I know that's a mouthful, but spindle cells are basically cells that have a syncytial pattern of growth. So what syncytial pattern of growth means is the cytoplasm connects, and this causes these cells to become fused, and then they kind of wrap around each other, which is why you have this whorled pattern to these spindle cells. Now what we have below here is these tumors can also present with psammoma bodies. And what a psammoma body is actually just concentric laminated calcifications. So you can see some calcifications here, 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 and this is a pretty easy image to remember. It's pretty distinct, and just remember this goes along with meningiomas. And of course I have some deeper explanations from AI for the whorled spindle cells here, and then of course the formation of those psammoma bodies. All right, so moving on from meningioma, I want to talk about the more malignant type of tumor in adults called a glioblastoma. And you know what? Before I actually talk about glioblastoma, I want to move on to moving back to meningioma. I want to talk about some of one of the tumors associated with I want to talk about a genetic condition that can result in meningioma. So early in life, you can be diagnosed, if you're unfortunate, with something called neurofibromatosis type 2. And this is an autosomal dominant condition, and it's due to a mutation in the NF2 gene on chromosome 22. And this is easy to remember because NF2, 22. And what the NF2 gene is it's a tumor suppressor gene that encodes a protein called Merlin. So Merlin's a tumor suppressor gene. So when you lose a gene that suppresses growth of cells, you're going to have cell growth. And some of the tumors that are associated with this decreased Merlin are, of course, meningiomas, but then you can have something called a bilateral vestibular schwannoma. Okay, so bilateral vestibular schwannoma. And this can obviously be associated with tumor of Schwann cells, per the name. And what I want to do is talk about a little bit what a vestibular schwannoma actually is. So obviously, you have your vestibular cochlear nerve, which is involved with hearing. And you have Schwann cells, which of course myelinate these neurons. And this tumor actually arises from these Schwann cells around cranial nerve 8, or the vestibular cochlear nerve. And this occurs at a cerebellar pontine angle, which is, looks like it's right around here. It's like there's your tumor there. And it can compress this vestibular cochlear nerve, which is involved with hearing. And this can cause hearing loss, tinnitus, which is just ringing in your ears, and then vertigo. Because again, the semicircular canals in your inner ear are involved with balance. So if you have a tumor compressing or not allowing that information to come from the semicircular canals, you can get vertigo. All right, so let's look at the histology of a bilateral vestibular schwannoma. And what you're going to see is zones of alternately dense and sparse cellularity. So this is what you would see in a bilateral vestibular schwannoma. All right, so now let's go over to glioblastomas. And before I want to talk about glioblastomas, I want to talk about astrocytoma, which is basically just an umbrella term encompassing two tumors we're going to talk about today. Now, those tumors are going to be glioblastoma and then pilocytic astrocytoma. Glioblastoma is going to be caused in adults, and it's going to arrive supratentorial, so above the tentorial cerebri, and this is going to be more common in adults. And then if it's infratentorial, it's going to usually be in children, and that's going to be that pilocytic astrocytoma. So moving up to glioblastoma, let's talk about some of the etiologies of it. And again, we've already kind of discussed this, but it's going to be prior radiation to the head, the most common cause. The histology of a glioblastoma is necrosis and or vascular proliferation. So this tumor is going to be growing very fast. So if we look at the pathophysiology of it, you're going to see amplification of epidermal growth factor receptor gene. So this is a gene involved with growing of tissue. And then inactivation of P10, which is a tumor suppressor gene, so suppressing tissue growth. So this is kind of a perfect storm that can happen. And this causes cells to grow very fast. They're very highly cellular, and they have a lot of mitotic activity. Of course, mitosis is just cell division. So you're going to see irregular hyperchromatic nuclei, which basically just means those nuclei in the cells are going to be very dense, making them very dark on histology image. And then you're also going to have eosinophilic glial fibrillary acidic protein show up in the cytoplasm. So this is a histo image of a glioblastoma. And what you can see is alternating areas of necrosis. So you can see necrosis here. This is just this pink area. You see a bunch of cells. This is just very fast growing cells. And then here's a blood vessel here, blood vessel that's growing. You see it's leaky, surrounding edema there. So that's pretty much it what I want to discuss on the histology of a glioblastoma. Let's go up here to the side effects or the symptoms of it. And again, you're going to have necrosis and vascular proliferation. And this can very quickly lead to death due to increased intracranial pressure due to all that leaky vessels and fast-growing tumor mass. The locations of a glioblastoma, again, are supratentorial, so you're going to see them within the cerebral hemisphere. And on gross image, sometimes they can present as a butterfly lesion. What a butterfly lesion is you have the corpus callosum separate the two hemispheres. Well, glioblastomas can cross the corpus callosum, making these wing-like structures. It's referred to as a butterfly lesion, and that's very common for a glioblastoma that's progressed. To work up a glioblastoma, MRIs would be the method of choice. Again, MRIs are very good at localizing soft tissue. And so you can see this one on a coronal section. There's a butterfly lesion, crosses the corpus callosum, axial lesion or an axial view, again, butterfly lesion. And they also are referred to as ring enhancing lesions. So this is a tumor right here. It looks like it's in the occipital lobe. You can see surrounding edema. That's going to compress the brain. Maybe it can compress those ventricles eventually. But all in all, it's going to lead to intracranial pressure, most common cause of death with a glioblastoma. To treat a glioblastoma, unfortunately, the prognosis is very poor. Life expectancy is 12 to 18 months, as you can see here on the right. So you're going to have to be very aggressive in treating this. They're really considered unresectable due to the cells extending beyond the main tumor mass. So you can see that on a microscope. So the cells, again, this is what contributes to the WHO grade 4. But what you're going to want to do is you're wanting to resect this tumor as much as you can if you end up becoming a neurosurgeon. And then you're going to want to hit it hard with radiation and chemotherapy. So that's pretty much all you can do for glioblastoma. Again, the prognosis is very poor. So it's very unfortunate if your patient gets diagnosed with this, but you're going to try to do as much as you can to prevent harm and give them the best options that they can. So now we're going to move on. So what I want to talk about now is I'm going to kind of bring together astrocytoma and the tumors associated with genetic conditions to talk about pilocytic astrocytoma. So again, a pilocytic astrocytoma is involved in that area of, it's an umbrella term that encompasses glioblastoma and pilocytic astrocytoma. So now we're going to move on to pilocytic astrocytoma. And this etiology is usually caused by if you're again diagnosed with neurofibromatosis type 1. So we already talked about neurofibromatosis type 2 with meningiomas and vestibular schwannomas. Now we're going to move on to neurofibromatosis type 1. And this is an autosomal dominant condition, which is due to the NF1 gene on chromosome 17 being mutated. And this gene encodes neurofibromin, which actually activates GTPase in the RAS pathway. So I'm not going to go into all about what the RAS pathway actually is, but just think of it as a secondary messenger pathway that leads to cell growth, survival, and proliferation. So it's basically the cell communicating with itself due to growth factors that it needs to grow, survive, and proliferate. And it gets inactivated by this NF1. So it actually activates GTPase, which actually turns it off. All right, so GTPase is going to break down this activated RAS. That's going to turn off this cascade, which would lead to decreased cell growth, survival, and decreased proliferation. All right, so if that can't work, you're going to have increased cell growth, increased cell survival, and increased cell proliferation. And that's what actually causes all of these tumors seen in neurofibromatosis type 1, which include neurofibromas, which are just these benign nerve sheath tumors here. You can see Café-au-lait spots, which are basically just they are darkened lesions or darkened macules on the body. And then you can have Lisch nodules, which show up as tumors within the iris of the eye. All right, and then you can have axillary freckling, so freckling in the axillary region. And then we already talked about Café-au-lait spots, which are flat, hyperpigmented macules. These usually typically appear in the first year of life. They increase as you get older in childhood. Another tumor that you can get, again, is pilocytic astrocytoma from neurofibromatosis type 1. And this is the most common primary brain tumor of childhood. It's very resectable with a Hu grade type 1. Again, it's below the tentorial line, so the line separating the cerebellum and the cerebrum. And what it is, it's whenever your MAPK pathway gets alterated. So again, your MAPK pathway, again, is a part of this pathway here. So I don't see the MAP protein off of my list here, but just know that that MAPK protein is involved with this here. And it's going to present with solid and cystic circumscribed tumors. So these tumors are going to be very solid and cystic, and this is in contrast to another tumor that we're going to discuss that presents in the cerebellum later on, called a medulloblastoma down here. All right, so these typically arise in the cerebellum, and this can have a mass effect. So again, remember the cerebellum is involved with balance and coordination, so this can present also with balance and coordination problems, but it can also obstruct the ventricular system, because remember the cerebellum is right behind that cerebral aqueduct and fourth ventricle, so it can compress on those, leading to increased CSF, increased intracranial pressure, and obstructive hydrocephalus. This one's actually very curable with resection. On histology, it is shown as biphasic appearances of compact areas of hair-like cells and Rosenthal fibers alternating with loose and myxoid regions. I know that's a lot of big words. Just know that it's very loose and dense areas. And this goes very well with solid and cystic solid and cystic parts of the tumor. So loose and dense, solid and cystic. Okay, so let's move on. I want to talk now. So we've already covered mainly most of the adult tumors that I want to discuss, but now we're going to continue on with child tumors that associate most commonly in childhood. Before we get there, I want to talk about two genetic conditions that can cause the next tumor we're going to talk about, and that is the very dangerous medulloblastoma. The first genetic condition I want to discuss is Li-Fraumeni syndrome. Li-Fraumeni syndrome is an autosomal dominant condition that is caused from a mutation of your TP53 gene, which is a tumor suppressor gene involved in a lot of cellular processes. It's one of the main proteins that stops cell division if something's going wrong. And if that gets mutated, you can have a lot of unfortunate consequences downstream. So it's involved with apoptosis and DNA repair. All right, so some of the manifestations are breast cancer, osteosarcoma, very dangerous bone cancer. Unfortunately, a very dangerous type of cancer here, and then acute leukemia, and then medulloblastoma. Before we get to medulloblastoma, I'll talk about one more syndrome. This is nevoid basal cell carcinoma syndrome. And again, basal cell carcinomas typically present on the skin. They're just this very slow growing types of tumors, most common type of skin cancer. And this is, again, an autosomal dominant condition. It's a germline mutation of the PITCH1 gene. Again, PITCH1 gene, tumor suppressor gene. And so you can see jaundice, palmar and plantar pits, calcification of the falx cerebri, which again is the dura mater in the cerebral hemispheres. You can have multiple basal cell carcinomas on the skin, and then you have a risk of medulloblastomas. So finally, we're going to get there, medulloblastomas. We're going to move to this part of the mind map, and medulloblastomas, we're going to start with the WHO grade. So the WHO grade's 4. So this is very unfortunate for whoever gets a medulloblastoma. It's very hard to treat. It arises in the cerebellum, so you can see a gross image here, and the cells usually extend beyond the tumor line. So they arise within the cerebellum, and unfortunately, they have a propensity for seeding the CSF. So basically what that means is they extend into the CSF system, and they can spread throughout anywhere the CSF touches. So that's spinal cord, anywhere in the brain, compress on nerve roots, and this can lead to weakness if those nerve roots are compressed, if those tumors spread throughout the CSF and land in the spinal cord. Some more signs and symptoms of the medulloblastoma is gait ataxia and truncal instability. It's very intuitive, right? So if the tumor arises in the cerebellum here, it can affect that vermis, which is the middle portion there of the cerebellum that extends to the brainstem. This can lead to truncal instability. Or if it's more on the peripheral parts of the cerebellum, which are in charge of the limbs, the arms and the legs, like the coordination, this can lead to something called gait ataxia. And ataxia just means like discoordination. So, and gait means walking. So your normal way of walking. So your walking is very uncoordinated, which is what gait ataxia is. And again, because it's in the cerebellum, and that's right behind the fourth ventricle, if it grows, it can compress the ventricular system or the CSF network, and this can lead to obstructive hydrocephalus. And again, if you have obstructive hydrocephalus, intracranial pressure can rise because then CSF is part of the big three, blood flow, mass, and CSF, and this can cause altered level of consciousness, nausea and vomiting, and headache. Usually the most common cause of death there. The histo is small, round, undifferentiated cells. So this honestly really reminds me of small cell carcinoma. It's kind of described the same way. You have blue cells, same as small cells. Small cell carcinoma, both present with blue cells. And then they have an increased nucleus to cytoplasm ratio. So that nucleus is going to be much larger than the surrounding cytoplasm, so they're very dense and compact. All right, so that's and we're going to talk about the workup here. So again, MRI, you can see that tumor there in the cerebellum. All right, so let's move on. Let's now talk about some of the other brain tumors that one can get. We're just going to go around in a circle here, and I didn't really have these a part of the tumors up here because they weren't really the most common, but these again can present in different times of life, so through infancy all the way to old age, just depending on what tumor they are, but we'll go through each one individually. Okay, so I want to start here with oligodendroglioma. And I don't have much to say about oligodendroglioma. The only things you really have to remember for step 1 is that the mutations are going to be a combined loss of 1p and 19q. And these are just, again, chromosome arms. So the p arm of the first chromosome and the q arm of the 19th chromosome. And then you can also have mutation of isocysteate dehydrogenase, which is an enzyme. So the epidemiology is they're going to present in middle age, so 25 to 45 years old. And they have a very low WHO rating, still not a 1, and still something to very much worry about. And the histology is you're going to have spherical nuclei with surrounding halo of vacuolated cytoplasm. So what this means is vacuolated just means you have fluid-filled spaces. So cytoplasm become very fluid-spaced, or fluid-filled, and the nuclei is going to be very spherical. And you can imagine this kind of looks like a fried egg. So they're going to be commented as fried egg appearance. You can kind of see that here on the histology image. See, you have a tumor here or a cell here, and this looks kind of like a fried egg. So you have the vacuolated cytoplasm, and you have the round nucleus. Now the vascular pattern is described as chicken wire. And there's another type of tumor that is described as chicken wire, and that's a renal cell carcinoma. We'll go through that in the GU section, but just remember that's also described as chicken wire. All right, and then calcification is often present 90% of the time. Now, in terms of the location of oligodendroglioma, it typically presents in the frontal lobes. And again, if it's in the frontal lobe, it can present very commonly with seizures, and that's usually in the white matter of the cerebral hemispheres. All right, so let's just continue on down here. So I want to talk now again about an ependymoma. So ependymoma is a tumor arising of the ependymal cells. Now, what the ependymal cells are tumors that line the ventricles. They kind of lock in the CSF, or they kind of just keep that CSF within the ventricular system, right? So that's what ependymal cells are. And they present in childhood and in adulthood, but they present differently in each age group. So in adults, the ependymoma is going to arise near the spinal cord. And again, you can have very much spinal nerve side effects and symptoms in adults. So if it's arising in the spinal cord, you can imagine you're present with weakness. So lower motor neuron lesions, pain, if it's compressing somewhere in the spinal cord, sensory loss. So again, those sensory neurons that are coming up from the dorsal medial meniscus pathways or lateral spinothalamic pathways, that sensory is going to be lost. And then you can also have radiculopathy. So if it's compressing on a nerve root. And what a radiculopathy is just numbness, tingling, and weakness along the path of an affected nerve. And these can be usually resectable in adults, so usually a better prognosis than if it presents in childhood. In childhood, on the other hand, it's going to arise near the fourth ventricle. So again, the fourth ventricle is where the CSF is created. So if it arises there, it can very much easily cause obstructive hydrocephalus. And again, obviously neurological deficits since it's in the brain. On histology image of an ependymoma, we're going to see rosette pattern with cells, okay? So rosette pattern kind of just means like this very flower-looking lesion. So this is a blood vessel, as you can see, white or red blood cells within there. And you can also see nucleus sticking out. That's going to be an endothelial cell. And then you can have the tumor cells surrounding it. So this is the ependymoma, or the ependymal cells that have, of course, mutated. All right, so now after going to ependymoma, I want to move on to primary CNS lymphoma. And what a primary CNS lymphoma is it's lymphoma that presents primarily directly into the CNS. So it's not a metastases, it's primarily directed in the CNS. And the etiologies, if you can imagine, since lymphoma, blood disorder, are due to either immunosuppressed patients or age. So basically immunosuppressed because your immune system decreases with age. All right, and then you can imagine some common causes of immunosuppression, so immunodeficiency syndrome or post-transplantation. And you can actually mark these cells, you can tag them. So you have CD19 plus positive and CD20 plus positive. So these are CD markers that are common for B cells, right? So typically the type of lymphoma is diffuse large B cell lymphoma, and this is how you discover that it's diffuse large B cell lymphoma, is you have a bunch of B cells within the tumor, and these test positive for CD19 and CD20. And also, these tumors can be latently infected with Epstein-Barr virus. So you can imagine if you do a cytology and Epstein-Barr virus shows up, that's a pretty common finding. All right, and the epidemiology, it presents in adults age around 60 plus. So moving on, we're going to move on to germ cell tumors. So germ cell tumors are basically tumors that affect the pineal gland. And here's a little bit of a review of what the pineal gland does. Is it's going to be in charge of your circadian rhythm. So it releases melatonin. I misspelled that, apologies, but melatonin, and that's going to be what controls your circadian rhythm, so your sleep-wake. To do that, it receives sympathetic input from the superior cervical ganglia, which is part of that sympathetic trunk that extends up into the neck. So it's going to receive sympathetic input from the superior cervical ganglia into the pineal gland, and that again produces melatonin. So germ cell tumors are tumors of that. And they most commonly, typically, mostly affect males more than females, and they present in the second decade of life. So one of the only germ cell tumors that I really want to discuss is something called a pineal tumor. So again, this is a tumor of the pineal gland, and it typically causes neurological dysfunction through three mechanisms: direct invasion of the pineal gland, compression of the pineal gland, and obstructive of CSF flow. And again, if it obstructs CSF flow, it presents with all the hydrocephalus symptoms, so headache, lethargy, increased intracranial pressure. The compression part of the neurodysfunction, I really want you to remember this, but it can cause Paranod syndrome. And what Paranod syndrome is a compression of the dorsal aspect of the upper midbrain, so the rostral portion of the upper midbrain. And this can actually put pressure on the pretectal region. What the pretectal region is very involved in the pupillary light reflex. So the pretectal region, whenever you shine a light in someone's eye, and of course goes through your optic nerve, the optic chiasm. After it goes out through the optic chiasm, those tracts go to the pretectal nucleus, and actually the pretectal nucleus divides neuronal tracts that go to both eyes. So you can imagine in Paranod syndrome, you won't be able to constrict your eyes. So mydriasis is a very common side effect or symptom of Paranod syndrome. The only one I have here is paralysis of upward gaze, because it can also very much be involved with compressing the superior colliculi, which is just tracts in the midbrain involved with putting your eyes or turning your eyes up, so looking up. This can be classically described as sun setting sign. So it looks like the sun is setting because you can't lift that iris above or look up, and they typically have raised eyebrows here. So that's pretty classic for Paranod syndrome with pineal tumors. So now I want to move on to something called a pituitary. We're going to move on from the pineal gland to the pituitary gland. And I'll talk about all of the tumors that you really need to know for boards, and this is just pituitary adenomas. And again, there's a couple of etiologies that can cause pituitary adenomas. A lot of them are sporadic, but one I want you to be familiar with is something called multiple endocrine neoplasia type 1. What multiple endocrine neoplasia type 1 is it's a loss of the MIN1 gene. And again, MIN1, 1, chromosome 11. So pretty easy to remember just like that, just like neurofibromatosis type 2 is chromosome 22. This is MIN1 and chromosome 11. Of course, menin is a tumor suppressor gene, so it suppresses growth. It can lead to pancreatic islet cell tumors, peripheral hyperplasia. These are not very important right now. Just remember that multiple endocrine neoplasia type 1, due to loss of menin, can lead to a pituitary adenoma. Now, the pituitary adenomas can present differently depending on where it is in the pituitary gland, but typically they can be classified as functioning or non-functioning. And what functioning means is it secretes one or more hormones. So of course, the pituitary gland is very involved in hormonal synthesis and release. So if it's a tumor of the pituitary gland, you can imagine that it can secrete one or more hormones as a side effect. And we'll get into the different types of pituitary adenomas in a second that are functioning, but first I want to discuss what a non-functioning pituitary adenoma is. And all that is it doesn't release hormones. But a common symptom of a pituitary adenoma that's non-functioning is a compression effect. So it can compress the optic chiasm, which, if you can remember what the optic chiasm is you have your eye here, right? And when light comes in, it shines on the back of your retina here, and then it takes it and travels to the optic nerve. And what happens is it actually, there's something called the optic chiasm here, which looks like this. So you have the other eye there, and the optic chiasm is this area in the brain that the tracts on the medial sides, so light coming on the medial retina can actually travel and cross back and go into the other side of the brain. So if it compresses that optic chiasm there, then those tracts that are in the medial part of the retina can't, you don't even have those because they can't get to where they need to go in the primary visual cortex. And because it's light coming from outside, you're going to lose your peripheral vision. So it's called bilateral hemianopia. And what it looks like is, say this is your visual field, you're going to lose vision on the periphery, just like this. So you really only have focus vision right there. So that's what bilateral hemianopia is. I'm going to erase this really quickly so we can continue our discussion. Okay, so let's move on to functioning pituitary adenomas. So what functioning pituitary adenomas do is they secrete one or more hormones. We're going to start out with prolactinoma. So prolactinoma is a tumor of the prolactin producing part of the pituitary gland. My name for it is a lactotroph adenoma. So again, this causes increased prolactin, and this can lead to galactouria. And what galactouria is it's just milk production in non-breastfeeding individuals. Okay, so the next one is corticotroph adenomas, and this is producing adrenocorticotropic ACTH. And this is, of course, can cause Cushing's disease. All right, so the next one is somatotroph adenomas, and this is growth hormone producing, and it presents typically whether the growth plate has closed or hasn't. So if the growth plate's already closed, it presents as acromegaly, and if the growth plate's open still, it can present as gigantism. The size classification is pretty easy to understand. If it's smaller than 1 centimeter, it's called a microadenoma. Larger, it's called a macroadenoma. So that's the only things I want to discuss about pituitary adenoma. Now we're going to discuss craniopharyngiomas. So craniopharyngiomas are tumors that arise from an embryological structure called Rathke's pouch. And the reason why I want to talk about this after pituitary adenomas is because Rathke's pouch is actually the embryological structure that turns into the pituitary gland. So it kind of goes along with the pituitary adenoma talk. But it's actually the most common supratentorial tumor of childhood. So remember, supratentorial is above the temporal cerebri, which is the area that separates the cerebellum and the cerebrum. And they're mostly commonly in adults, but this tumor can actually present in childhood. Okay, so it's the most common supratentorial tumor in childhood. It's actually 5 to 10% of all childhood brain tumors. It's not something to take lightly. It's very much common, and it presents as solid and cystic. So remember, solid and cystic. Another tumor that can cause solid and cystic lesions is remember, it's the pilocytic astrocytoma, right? So very solid and cystic there, circumscribed lesions within the cerebellum. But when in craniopharyngioma, it presents in the suprasellar region. And the suprasellar region is again adjacent to this optic chiasm. So remember, the optic chiasm, you have those medial retinal pathways, light coming from the periphery. Remember, they shine to the back of the retina. It can't get to the primary visual cortex, so you present with bilateral hemianopia. All right, and they can also compress the pituitary gland, leading to a pituitary hormone deficiency. And this is a Hu grade type 1, so very resectable. Peaks 5 to 15 years of life, so childhood and teenage years. Histology. It's very interesting. You have these cholesterol crystals found in a motor oil-like fluid within the tumor. So if you extract the fluid from the tumor, it's going to look very dark, and then you can get cholesterol crystals from that. It's going to be very squamous. It's going to be squamous epithelium with calcifications. So you have calcifications here, squamous epithelial areas here and here. It's very classic for a craniopharyngioma. And then to work this up, you're again want to do an MRI, and you can see in that pre-suprasellar region there, it's very close to the pituitary gland and the optic chiasm. So that's again bilateral hemianopia and pituitary hormone problems. Again, to treat this is going to be a surgical resection like most tumors. Again, we're going to end off with a gross image of it here. This is the tumor here. Again, it's compressing, so it's compressing those ventricles, compressing the optic chiasm. All right, everybody, so it looks like that is all of the tumors of the brain and spinal cord. Please like and subscribe this video. If you found this interesting, please comment and let me know if there's anything else y'all want me to discuss. Other than that, I hope you'll have a good rest of your day, and we'll see you next time.